seasonal trends and diagnostic diagnostic tests. And just at the outset, the overview of my talk will cover the following. So I'll go through epidemiology, a bit of viral characteristics, a bit on seasonal viruses and how they are named, a few points on antigenic changes that cover antigenic shift and drift, some aspects of molecular testing and what we offer here at AMPATH. I will also go through statistical trends, looking at the NICD and AMPATH surveillance of PCR and what we find, and just a few points on prevention. I must say that the talk is not high-powered. It's a general overview, and I think there's a good few take-home messages that we will cover. So to begin, we know that the annual influenza epidemic results in severe illness in up to 5 million cases globally, and it's also responsible for a huge number of deaths, up to 650,000 globally. And what we do know is that one of the complications of influenza is that it causes pneumonia, a lower respiratory tract infection, and generally, those who have pneumonia, up to 10% of them will test positive for influenza during the peak seasons. Out of a modeling study done in South Africa using case-based and ecological data, this was done between the period of 2013 to 2015, on average, there was just under 20% of South Africans who had influenza-associated illness, of which generally the majority are mild, just around 98%. But severity adds up to about 1.2%, and the fatal disease is in under 1%. So that is important to note. The highest rates of influenza-associated hospitalization are in those in the extremes of age, so greater than 65 years, in those people living with HIV, and generally in children under a year of age. Looking at influenza-associated deaths in women of childbearing age in South Africa, out of studies, the literature shows that the majority of these deaths occurred in people living with HIV, and the mortality was threefold higher in pregnant compared with non-pregnant women. That's an alarming statistic. So the influenza season usually occurs between May and September in South Africa, and approximately 14% of inpatients with a lower respiratory tract infection and about 25% of patients with an influenza-like illness will have a positive PCR test for influenza. The highest number of your uncomplicated mild cases normally occur in people up to the age of 24 or under 25. We know that in those people who have comorbidities, influenza will trigger exacerbations, namely in things like diabetes or diseases like diabetes, pre-existing pulmonary infections, COPD, asthma, and in cardiovascular disease. So basically, those people with chronic medical conditions are at high risk for influenza complications. Surveillance data from SA also showed that having any underlying illness was a risk factor for mortality due to flu. So the burden of hospitalizations and death due to influenza can also vary substantially from year to year. And this would depend on what strain is circulating and how virulent it is. So when we look at influenza viruses, there are a few things that are important. For what it's worth, in the grand picture of things, it's a single-strand RNA virus and it belongs to the orthomyxoviridae family. And you have genera that are A, B, C, and D. Influenza A and B generally cause epidemics in humans, And the main antigenic determinants are the hemagglutinin and neuraminidase transmembrane glycoproteins. So they are otherwise known as your HA or NA proteins. And these proteins are critical for the pathogenesis of the disease, and it's also the major target for neutralizing antibodies due to vaccinations that we receive. There are only 3 H subtypes or hemagglutinin subtypes, the H1, H2, and H3, and 2 N subtypes, your N1 and N2, that have circulated consistently in the human population, and they are responsible for the annual epidemics. Pandemics can occur when you have a new and different influenza virus that emerges and infects people. And this has the ability to spread efficiently amongst people and against people who have little or no immunity. And we know this all too well from the swine flu that happened in 2009, and not too long ago, the COVID pandemic that we all endured as a virus. So the important thing about the influenza viruses that circulate in animal species, otherwise known as zoonotic influenza viruses, we speak of the avian influenza A virus subtypes. So there are many, but the common ones are subtypes A, H5N1, H5N6, H7N7, H7N7, N9, and H9N2. And then, as mentioned, the swine influenza A virus subtypes, and these can sporadically be transmitted to humans. So currently, the zoonotic influenzas are rare and generally requires close contact with animals such as pigs or birds, poultry, etc. And human-to-human transmission is very uncommon, all right? So looking at the structure of the virus, I mentioned the subtypes that are based on the hemagglutinin and the neuraminidase surface proteins, and you see those depicted in blue and in red that literally sit on your transmembrane proteins, and they are stimulants to our immune system, and also that's where we have antibodies being made against these proteins. Now, there are 18 different HA subtypes and 11 different NA subtypes, and they're critical for pathogenesis, and as mentioned, antibodies are directed against them. So how do flu viruses change? So the change can be described in 2 forms. One is drift and shift. So antigenic drift. These speak to small changes or mutations in the genes of influenza viruses, and these can lead to changes in the surface proteins of the virus. The changes associated with the drift happen continually over time as the influenza viruses replicate. And these small genetic changes that occur over time usually produce viruses that are closely related to one another and share similar antigenic properties. Our immune systems generate antibodies to these proteins, and they are usually protective. So our immune system, once creating these antibodies, will generally confer cross-protection against these antigenically similar flu virus. So antigenic drift is an important reason why people can get flu multiple times over the course of their lives, right? So your immunity is not long-lasting, it is transient, but you do get cross-protection due to the small changes or mutations called drift. It is also a primary reason why the composition of flu vaccines for use in both hemispheres is reviewed annually and updated as needed to keep up with this evolving flu virus. All right, so that speaks to surveillance. Moving on to antigenic shift, this tends to be a more abrupt, major change in the influenza A virus. And it results in a new hemagglutinin protein or a new raminidase protein or both. And these can then infect humans. So literally, it results in a new flu A subtype infecting people for the first time. So it's novel, and we have no immunity against it. This, thankfully, happens very infrequently. So shift can happen if an influenza virus from an animal population also gains the ability to infect humans. That's important. Such animal origin viruses can contain these combinations that are different enough from the human strains that most people do not have immunity to this novel virus. And hence, this shift occurs and causes pandemics. So as mentioned, in 2009, we had the H1N1 virus with genes from viruses originating from North America, swine and Eurasian swine, humans and birds, and emerged to infect people and quickly spread, causing the pandemic. To date, we've had 4 flu pandemics in the past 100 years, and I think the one that is commonly known is the so-called Spanish flu in 1918, which was also a H1N1 virus. We had a H3N2 virus that caused a pandemic in 1968, and the H2N2 between the year 1957 and 1958. So the interesting thing is, how do we actually name these influenza viruses? Because it all sounds so confusing and it can be quite complex. So I got this from the CDC, USA CDC website, and I thought it quite nicely described how the nomenclature of viruses occurs. And this is an internationally accepted convention, and it's endorsed by the World Health Organization since 1979, and the following components are used in the approach. So we speak first of the antigenic type, either the influenza A, B, C, or D. As mentioned, in humans, A and B are the culprits. The host of origin, so where did this originate from? Was it swine, was it poultry, etc.? Generally, for human origin viruses, there's no host of origin that's designated, so you won't have a designation given there. It speaks to the geographical origin, the strain number, and the year of collection. So, for example, going back to the host of origin, if it was avian influenza A and it came from the duck, it would be influenza A H1N1 duck. It was found in Alberta, which is the geographical origin, and it's given the strain number, which is 35, and the year of collection, which is 76, so forth. I think those are just the takeaway points from this slide. And in this slide, it quite nicely puts it together. So you're looking at the virus type, the place the virus was isolated, what the strain number is, which year it was isolated, and what's the subtype. Okay, so it's a H3N2 or a H1N1, for example. Right? And then it brings me to this seasonal virus slide, which depicts the types of virus, again, what your subtypes are, and then it speaks of the clades and the subclades, which are also known as groups and subgroups. This can get quite complex, and to be very honest, the clades and subclades speaks more to interests of research and surveillance and further sequencing and subtyping, which happens at an academic level. But for the interests of us understanding the seasonal influenza viruses, I think if we look at influenza A, causing the most human illness during the flu season, our subtypes are routinely the A H1N1 and the AH3N2, which is circulating. And with regards to the influenza B virus, it speaks to the lineages where the Victoria and the Yamagata are the 2 main subtypes of influenza B. All right. I think the important thing to know, the takeaway from this slide, is that the numerous uncomplicated symptomatology, the cough, the headache, the rhinitis, sore throat, weakness, fever, which could be any respiratory virus during flu season, and the fact that it's transmitted through respiratory droplet spread, through touch. So your etiquette in ensuring that you cover your sneezes and your coughs, or you even mask up at times to prevent the onward transmission of this highly infectious virus. All right. So just with regards to general points on influenza, and I think this is important. Typically, the incubation period is between a day and 4 days, on average 2 days, and most persons will shed virus from a few days before symptoms start to about a week after illness onset. And we know that the very young children can be infectious for up to 10 days or more. And adults with severe disease who have pneumonia and are coughing or really ill can shed virus for more than 10 days. And in those particular high-risk groups that are immunocompromised, or our oncology patients and so forth, those patients on immunosuppressants where their disease may be long and protracted, they can shed periods for even longer. And just as a note, we did see this during the COVID pandemic epidemic as well, where we had prolonged shedding of virus even after 10 days. So transmission is a problem, and it can be ongoing past symptomatology. The important thing to know is, as we mentioned in the earlier slides, that most of the flu will be uncomplicated and mild. So if you're healthy and you don't have comorbid disease, you're going to get an uncomplicated illness and you will recover without any sequelae. But those who have severe influenza then are going to end up having lower respiratory tract infections, where pneumonia becomes a presentation and all the clinical signs are evident. You can have central nervous system involvement and an exacerbation of your underlying medical conditions. These need to be importantly recognized, and hospitalization needed because mortality is a problem. Who are your high-risk groups then? And this I took out of our NICD 2024 guideline. As mentioned, pregnant women, those living with HIV, people who have tuberculosis or any chronic diseases, pulmonary diseases, cardiovascular conditions, malignancies, people who have, for example, rheumatoid arthritis, SLE, who are on immunosuppressive medication, chronic renal dialysis, nephrotic syndrome, people with chronic liver disease, and so forth, fall into those categories. As mentioned, those greater than 65 tend to be those who develop complicated influenza disease, those who are morbidly obese, and in our very young. So let's talk a little bit about diagnostic testing. And I think we've come a long way from the traditional methods of viral diagnosis, where back in the day we do shell vial culture. It would take up to 3 weeks or longer to grow various viruses. It would become contaminated. There were numerous types of stains that needed to be done to actually look to see for cytopathic effect and so forth. And thankfully, all those are in the past and tend to be limited only to research background, where they investigate viruses and look for specific trends under the microscope. Now, in line with molecular diagnostics and technology that has evolved, the current method of choice for diagnosing flu is the PCR. It's a real-time multiplex PCR, which is known as the polymerase chain reaction. It is the gold standard, not only for influenza, but generally for respiratory tract pathogens. The sensitivity and specificity of these diagnostic modalities are far superior and highly accurate. They're based on nucleic acid analysis and detection, and it can be done on many respiratory tract specimens. And we tend to do it, as with most infections, during the acute phase, so when you're symptomatic, because the yield will be greater, and that speaks to increased sensitivity and also specificity. The great thing about these rapid molecular diagnostic tests is that the turnaround time is generally within 24 hours. We say that is a maximum, but generally, from the time of receipt in the lab, these tests are processed as urgent, and we get them out as soon as possible. So favorably in less than 6 hours, or even sooner. They are high throughput tests, and they go into platforms where they actually allow for high throughput. Generally, these are batched, but even with that, they come out in a very quick turnaround time. With regards to what's offered at AMPATH, we have several different options for detecting respiratory pathogens. I think the choice of a test is generally determined by the requesting clinician based on their clinical assessment. What's the suspected respiratory pathogen? How urgent is that result? What is the implication of the result in how I'm going to manage my patient, both at outpatient and inpatient level? Cost is very important, and obviously tests are expensive because they are new technology and so forth. And how do our medical schemes reimburse these tests? So these are all things to be considered in the choice of asking for a test. So I think the important point to make is that for uncomplicated illness, we don't routinely say that you need to have a lab test done. So a test, like with any test that is requested by a clinician, is very much decided upon by clinical evaluation and severity of illness. So again, for uncomplicated illness, even guidelines will tell you routine tests or PCR tests are not recommended. But testing is important for those who meet the criteria for complicated or severe influenza, where that test result actually helps you in patient management. So there are various tests for that, different types of multiplex PCR, both a comprehensive or a short test, and we'll come to that soon. Then you can also test for those cases where you have clustering of infection. And then we speak about an outbreak, for example, or if we liken it to a small frail care center or a nursing home or a healthcare facility where you may quickly want to know what's going on, and then you can either do a rapid test or you can do a PCR-based test. So I think the types of tests will become important, and we'll elaborate soon. The important thing about influenza is that your initial treatment decision should not be based on should be based on clinical presentation, and should be delayed based on what the lab test is going to say. So start treatment, which would be your oseltamivir antiviral, based on how the patient presents. If they're sick enough or ill enough to start treatment, then you go for that. And you can always wait for the result thereafter, but you start immediately. With rapid influenza diagnostic tests, the point to note here is that they have a high specificity, but they have a lower sensitivity compared to PCR. They can be used for a quick diagnosis where cost is a limiting factor, but it's not meant to replace PCR. But certainly as a point of care test, it can be used very effectively. And generally, when the prevalence is high, then you're going to get good results, good sensitivity, and high probability, positive predictive value from these tests. All right. So the important thing to know as well, symptomatology, as one of the earlier slides showed, is that respiratory symptoms don't tell you as to what virus you're dealing with. So you could be having a multitude of viruses coexisting 2 to 3 at times. And the common one is your SARS-CoV-2 may present in the same way as influenza. But these two viruses are important because they speak to how clinical management is informed and also public health response. So knowing what you have is important because you know how to then further treat and how to follow your infection prevention protocols. So where influenza and COVID co-infection is suspected in a hospitalized patient, we certainly say in a hospitalized patient, so this is complicated as well, that you should do a multiplex PCR for simultaneous detection when available. And depending on the clinical presentation, you can also test for other viral and bacterial pathogens that are causing severe respiratory illness. Important to note that with influenza, one of the complications is superimposed bacterial infection. And when you do your comprehensive respiratory testing as an inpatient, this actually helps to tell you what are your co-infecting viruses, are there any atypical bacteria, and there are certain comprehensive panels that we do in very ill patients which actually let us know what bacteria are on board. So certainly molecular diagnostics have evolved to the point where currently as inpatient, part of inpatient management, they are priceless. So coming back to what we do at AMPATH, I think the very important thing to know is that all tests that are offered are in keeping with what is FDA approved, endorsed by the World Health Organization, and certainly SAPRA approved. We go through a rigorous quality assurance process, and this ensures that our testing platforms are totally up to date. We have comprehensive validation and verification procedures to ensure accuracy in the way we report our results, and it's the standard benchmark that we have for excellence. So talking about your comprehensive panels and your shorter multiplex PCR panels that are available for influenza A and B, we have the respiratory panel PCR, and this is comprehensive. Apart from influenza A and B, it will also tell you whether you have other circulating viruses like your COVID, SARS-CoV-2, adenovirus, rhino, and enterovirus, your other common cold viruses, and I'll show you a slide shortly. And then we speak of your shorter panels, which we offer as the COV-TRI PCR, and that's because it covers your influenza A, B, the respiratory syncytial virus, and your SARS-CoV-2. And as mentioned, we've just recently launched our rapid influenza diagnostic test, which is a point-of-care test. It's a lateral flow assay, and it's very efficient in the right area where we need to test. And that's generally done on the usual throat swabs, nasal swabs, and nasopharyngeal swabs. The pneumonia panel PCR, as I mentioned, we use mainly in ICU, so I wouldn't really want to cover it in this talk, but just for completeness, that is one of the other panels that we offer. There are further panels, respiratory panels that speak to shorter detection, but I think for the interest of for influenza, I'll just speak to what is necessary. Important to know that if you visit our website, you'll get much more information on codes and pricing, so forth. I think the take-home message for all diagnostic tests, there are lots of pre-analytical factors that play a role into that eventual quality product that will be sent to the client. So how do we take the specimen? What type of specimen is taken? Is it a good quality? Is it representative of the site of infection? The timing of collection? Are we taking it for a symptomatic individual versus an asymptomatic individual? How are we transporting it, and how are we storing this? And this speaks very much to what happens at the lab and how we have all of that in place, so we ensure that we do not compromise that sample before we put it into our machines and so forth. And I think very important is that when you have a negative test, but your clinical suspicion is high, clinicians can consider repeat testing or serial testing. And I will just use COVID, the time of COVID as an example, because we saw many patients who were negative, and then upon retesting, they were positive. As the virus did shed and they became more symptomatic, the sensitivity of the test picked up more material. So I think if your clinical suspicion is high for influenza and you need to retest them, so be it, you can. Obviously, cost is a limiting factor, but when you really need to know the result for whatever reason, then that is allowed. So again, who do we test? So for these shorter panels where we're looking at your influenza A, B, your RSV, and COVID, I think your pediatric patients are important. They are the vulnerable. So, we want to see what's going on. Is there RSV? Is there influenza? Do we need to start Tamiflu? And do we need to give nebulization and so forth if you have RSV and influenza happening? Is there COVID and influenza going on in the patient? How do we treat? How do we manage? What are the infection protocols that we follow both at home and maybe in hospital as well? So basically appropriate and management. In your elderly, immunocompromised, and other patient groups with severe disease, certainly this is a test that we should consider. Where you cannot afford to do the respiratory multiplex panels that are more expensive and comprehensive, then this certainly is a good test to do. Also, I think important to note is that because of the overlapping symptomatology and knowing whether this is a virus versus a bacterial infection, in the early stages, you may not need to prescribe an antibiotic if you know that this is influenza or COVID or RSV, and hence you will have judicious prescribing practices. So indirectly, it speaks to your antimicrobial stewardship, right? This slide just depicts what I was speaking to earlier, the adenovirus, the circulating common cold coronaviruses depicted in your multiplex PCR, your human metapneumovirus. The important thing here highlighted in purple is that the multiplex PCR, which is a little bit more comprehensive and slightly more expensive, does tell you whether you have the H1, the H3, the H1 2009, or whether you have influenza B. But I think the important thing to note is that all of them are more important from a surveillance perspective to know what's trending, but your management will be the same, irrespective of whether you have flu A H1 or flu A H3, and whether you have influenza B, you will still manage the patient the same way and prescribe oseltamivir for all of them. The important thing talking about bacteria is that the atypical bacteria get picked up in these tests, and atypical bacteria can also cause what we call a walking pneumonia. So patients are quite well, but they actually have these atypical bugs, and the important thing about this is the routine beta-lactams like your amoxicillins and your augmentins and your cephalosporins are not what is used to treat these bacteria, but rather your macrolide antibiotics are used to treat. So again, there's a lot of value in multiplex PCR testing in the right patient because it gives you a lot of information. The limiting factor, as mentioned, is cost. I think the important thing is with regards to rapid testing, and as I said, we are now doing rapid flu tests because it's highly prevalent and it's flu season. If you get a negative test, I think the important thing to note here is a negative result does not exclude the possibility of flu A or B. And as we spoke of earlier, the rapid tests are less sensitive compared to your real-time PCRs, and hence you can get a false negative test. So a PCR test is recommended if the patient has flu-like symptoms or other clinical features of influenza, because we don't want you walking away thinking that I don't have flu, it's negative, and hence I'm fine. I think that's important to know that the sensitivity of the test differs from a PCR. Again, I think important to note is that if you have a clinical suspicion, and that's always paramount, then you will start antiviral treatment as indicated. You will not base it on the lab test. So I will now move over into some statistical trends. So these statistical trends that I will go through, I made use of the NICD website that actually looks at weekly surveillance of influenza A in the human population. And these statistics were as relevant as the 4th of June. So this was up-to-date information that I'm presenting. So I think before we get into a few of the slides, the important thing to know is that during our 2019, 2020, 2021, COVID was very much what we were dealing with. So during 2020, your influenza A and B virus circulation was at very low levels. We were in a pandemic. We had COVID that was wreaking havoc, all right? So influenza A atypically started only increasing really out of the flu season. So we saw an increase over September, October, and November of 2021. Similarly, our respiratory syncytial virus infections followed an atypical course, and that with the rate of detection only starting to increase during October 2020. So the increase in RSV continued during January and February, with the majority of your positive cases being detected mainly in our pediatric patients. So as your COVID numbers decreased, there was an upward trend of the circulating viruses that entered the spotlight. So we came off our public health restrictions. People were back to being, in open spaces, and obviously transmission was happening of the other viruses as well. So we started to see an emergence of our so-called usual suspects, but at an atypical time. They followed an atypical course. And hence also the respiratory molecular panels started to adjust what they could detect so that they were more relevant and spoke to what we were seeing at the time. So it spoke to surveillance. Right. So looking at this slide, and this is from the Center of Respiratory Diseases and Meningitis, NICD, and looking at our flu season for 2024. And in this figure, it speaks to the influenza surveillance epidemic threshold summary using outpatient influenza-like illness sentinel surveillance, South Africa. So they looked at sentinel sites and they looked at surveillance, looking at what the epidemic thresholds were. And this was over your epidemiological weeks, and it looked at your 3-week moving average. And it is a little bit of a busy slide, but what I want to draw your attention to is your colors that depict 2022, which is green, your 2023, which is a blue, a turquoise blue, and then your 2024, all right? So the thing that pops out a little bit is that if we look at your 2022, which is green in your epidemiological weeks, well, so just week 1 to week 51, so basically at the start of the year, as we're looking at January, you'll see that for 2023, 2022, there was not much happening early in January, but in 2024, there was some influenza activity at outpatient level that was happening actually prior to the usual flu season. And then in week 17, as we know, in red, you can see a steep inclination towards how your moving average increased, and it was starting to cross the high threshold or peaking towards the high threshold. So basically, this speaks to some influenza activity happening in 2024 earlier than usual, right? Looking at this stat and this graph, again drawing your your attention to the colors, green being 2022, 24 is your red, and the blue is 2023, you will see that using the inpatient pneumonia sentinel surveillance, so this is inpatient, those patients who got admitted due to complications, this happened pretty much similarly to what happened in 2023, and not so much 2022. As I said, COVID tended to be more in play and other viruses more in play, but our 2023 and 2024 stats seem similar. And 2024 is certainly heading towards peak as of the 26th May 2024. In this slide, which looks at the proportion of inpatient admissions in private hospitals with respiratory illness according to what they code for medical aids between January 2023 to May 2024, you can see that there was actually quite a high proportion of patients with codes for admission. So respiratory illness was absolutely evident in the first 21, I couldn't say first 21 weeks, but these are epi weeks, but this is speaking from 2023 to May 2024. And you can see that it is certainly alarming where you have sick patients being admitted. The very interesting thing about this slide, and I draw you to the attention of the yellow color, and this speaks to the number of positive specimens, and this speaks to what was found as part of your subtyping and lineage in all age groups for lab-confirmed influenza cases. And this is for 2024. You can see that your influenza A, H1N1, PDM or pandemic 2009 was the most or is the most prevalent influenza A circulating strain. Your H3N2 actually is minimal, and your influenza B Yamagata is also minimal. You will see that between weeks, say maybe 13, 14, 15, 16, it was low, and then literally 16 going upward, we're starting to see peak. And this could be because obviously more people are ill, testing, and obviously getting admitted as well. So these are lab confirmed cases. You must know there are many people who haven't tested, so highly likely that the numbers will be higher. So just a quick summary of the slides. The important things to know is that week 17 is generally the starting week for flu season, for influenza season. There was a steady increase in the number of influenza cases from the pneumonia sentinel sites. The 2024 flu season transmission and impact are at a moderate level. The detected subtype is the A, H1N1, PDM09, all right, followed by influenza B, Victoria strain, or Victoria lineage. And I think that is the take-home message from this slide. Okay, so moving on to my AMPAT surveillance data. This is just to illustrate similar things, but I think the good thing about this slide and what I wanted to show you is when we use our multiplex PCR assays, the information that we get is truly gold and speaks to a lot of what happens with our viral trends and surveillance. So I put this one up to show you the difference between December 2022 and January 2023. And I'd like your eyes to visit that speaks to your influenza rate. So if you see 2022, which is in blue, it's under 5%, and in January 2023, it's actually close on to 3%. So it was starting up, but still very low numbers as of last year, January. But what we did see was a little bit of COVID sitting under, around 12%, and the usual rhinovirus, enterovirus that was always interplaying, and a little bit of your adenovirus that had come up at 15%. And this was across all age groups. And if I look at this slide and I'm looking at the epidemiological week for 2022 from week 1 to 52, then, our peak is at around 35%, usually during influenza season, which is in keeping with what we've been discussing. To alert you to this, I want your eyes to look at influenza again, looking at February 23 and March 23, still very low rates, or less than 5% for influenza A. And the important thing here is that our RSV started to emerge. And I'm sure as clinicians, you would have seen a lot of RSV in your practices as well as part of admissions. In May and June of 2023, here you see the absolute increase in your prevalence of influenza A. So in May 2023, the blue graph shows it at around 38% and just around 30% in June. Okay. At the same time, COVID, there was less than 10% of COVID circulating at that time. And in the background, there's always rhinovirus and enterovirus that's at play. Then in 2023, also looking at the epidemiological weeks, I think this speaks to, again, your influenza A in blue, the blue graphs that are peaking during week 17, week 22, and all peaking at around 45%. And you can see RSV in the yellow. It's not coming across very strongly, but in the yellow, you see RSV that came up earlier, up to 30% in the earlier weeks. So we did have a problem with RSV last year. And your COVID was minimal. 2024. So in this slide, again, I want you to focus at the end of the slide where we're looking at week 17, 18, or from week 14 to 18, you will see influenza in your gray, and that's showing you the upward trending percentage, 10%, 17%, 20%, 26%, and you can see 34% at week 18. COVID is not a big contender, and RSV is in the background. But here, you'll see that we peaked at around week 20 at around 43%. Week 22, it's down to 32%. Okay, so I think the beauty of PCR surveillance is actually the wealth of information that you can deduce, and it speaks to being able to actually see what's going on in the communities, what's going on in hospitals, and it actually then influences your management. It also allows you to be discerning about what pathogen is at play, and this can target specific treatment modalities and also effect infection control measures. As I mentioned earlier, antibiotic stewardship is spoken to indirectly because we know we don't have to prescribe antibiotics just off the bat. We need to revisit vaccination status and promote uptake when interpreting the trends. Limitation, again, is that it is lab-based surveillance. These are tests that are expensive. They are covered by medical aid at outpatient level, especially your short panels of testing. But it's not part of routine healthcare diagnostics, certainly not at public sector level. We need to use any test judiciously. So as a clinician, you will always consider what test to do and do it properly. So that's diagnostic stewardship. I think I would not end this talk properly if I do not speak of prevention. So prevention is always better than cure, and we do know that vaccination is the most effective method for prevention of the complications of influenza. And in a randomized controlled trial that was done in South Africa, it showed that when pregnant women received the influenza vaccine, their risk of developing influenza was halved, as was the risk to their infants in the first 24 weeks of life. The vaccine was safe and efficacious. In the elderly, even though you may not mount a great, robust response to the vaccine, it's less effective, but it certainly does reduce the incidence of severe disease, so it prevents your bronchopneumonia and your hospital admissions and your mortality. So I think it's very important that surveillance has a huge part of what we do. The World Health Organization continually monitors epidemiology and speaks to how our vaccines are driven for each year. All right. So with regards to the vaccine, just important to know that it's for everybody, apart from those under 6 months of age. But what we like to do is prioritize those that are at high risk for complications. So always remember your healthcare workers, those greater than 65 years of age, those with your comorbidities, pregnant women. So there's a trivalent inactivated flu vaccine as well as a quadrivalent inactivated flu vaccine. And these cover all strains that we've been talking about as part of surveillance, and they ensure that you are protected from circulating strains. With regards to contraindications to vaccine, I think the important thing to know is that if you have a mild egg protein allergy, it's not a contraindication to receiving the influenza vaccine. If you have had a severe anaphylactic hypersensitivity to any vaccine component or to a previous influenza vaccine, certainly you would not want to take the vaccine. So a careful history that's important to distinguish between anaphylaxis and other allergic reactions is a must. Okay. If you've had a moderate illness, respiratory illness with or without fever, I think you should wait until your symptoms have resolved and then take your immunization. Okay, so the take-home message, again, is that we know influenza causes severe illness with a resultant increase in morbidity and mortality. Vaccination is recommended for all age groups apart from the very, very young. And it's the primary means for preventing seasonal influenza infection and its complications. You should actually take it sufficiently early because it takes about 2 weeks to develop a good immune response. So the best time to take it is before your influenza season. But also getting it at a later stage will still protect you for the rest of the season. And it's important, again, that the high-risk groups get vaccinated. Diagnostic testing has a very valuable contribution to patient management, both at outpatient and inpatient level. It speaks to surveillance, to antimicrobial stewardship. And I think certainly if you can afford to test, then you must. The important thing is that treatment decisions should be based on your clinical presentation and should not be delayed pending a lab confirmation of influenza. And also treatment should be generally reserved for those with more severe disease and with a background comorbidity. If you are healthy and well and you have mild disease, then generally you don't really have to take an antiviral. Many thanks for listening, and these were my references.